Please, can you start?
My name is John Harrison. I'm a psychologist based here in the UK, and very sadly for me, I am currently in the UK rather than on beautiful Brač Island with the rest of you. I checked the weather before I started making this recording, and it's a lot warmer where you are than where I am. So I very much miss not being there with you. It's a fantastically busy time in Alzheimer's disease, which makes your meeting timing absolutely perfect. But it unfortunately does keep me from joining you. Nonetheless, I'm delighted to have this chance to join you remotely, and this feels like a very hot topic given the news last week from Eisai and potentially more exciting news from Roche and Lilly in the next few months. But before I begin, a huge thank you to the organising committee. I'm always thrilled to have the opportunity to present at this event. And this is no exception. So thank you very much indeed to everybody connected with this and everybody connected with the organisation as well, who have been fantastically helpful in getting me prepared for a remote presentation with hopefully some vibrant Q&A after I'm done. So my role here today is to address what I think has been an ongoing issue for a really very long time, probably longer than would reasonably be the case ordinarily. I don't think what I'm about to say is completely controversial, or in fact even slightly controversial, but for some curious reason the field of Alzheimer's disease clinical trial work really hasn't moved with the developments that we in the academic and clinical side have witnessed in the last 20 years, and actually they haven't really kept abreast of developments that we've acknowledged in the last 30 to 40 years. So today what I'd like to do is just think about how we might better assess new possible treatments for Alzheimer's disease. And the targets of my audience today is very much this title. So should we be targeting cognitive domains other than memory in Alzheimer's disease? What I plan to do in the next 25 minutes or so is offer a picture of where we are currently, a picture of what we might choose to aspire to, and try to give you some reassurance that this isn't just opinion-based. There's actually some really good evidence to support the idea that we could and should do better than is currently the case. So let me begin with, I'm afraid, my disclosure side. This is really just a list of those people who have been kind enough to pay me for my assistance. It's quite a long list and I thank them all, but rather than go through it in detail now, if I could make the offer to anybody that wants to take a deep dive, I will post this slide onto my academia page, which will be referenced at the end of the presentation. So if you are keen to discover where my perceived or actual conflicts of interest lie, I'll make this data available to anybody that would care to view it and download it and look in more detail. Okay, so the meat of the presentation. What am I going to talk about today? Well, I think I've signposted very largely the direction of travel. So I'm going to begin by talking about the kinds of cognitive deficits that we see in early Alzheimer's disease. This seems to me a really good place to start. And I think in the last 20 years in particular, our understanding of the variety of presentation has become much more sophisticated. What's curious is that the clinical trial community don't seem to have kept up with the developments that we've witnessed as an academic community. I'm then going to talk about where we are, and what I mean there very much is in the context of where we are with respect to clinical drug trials. So I'm going to be talking about what are generally described as the gold standard measures, but I think hopefully you'll agree with me after I present, they really aren't very golden. I would judge that they're probably bronze at best. But they are very conventional, they're typically used, and it's worth having an exploration of them before we think about how we might do better, just to build a picture of current practice. And then the rest of the presentation is going to be looking at what could we do better? So where do we need to be? What do I mean by where do we need to be? Well, what kinds of areas of cognition should we be looking at? Is there any evidence that they are capable of being improved by interventional treatments? And what kinds of domains are the ones where the focus ought to be? So hopefully a good gestalt for you of the proposition that we're trying to evaluate, are treatments working, what we currently do, and what I would judge to be evidence that we could and should do better. And that last section will be supported by data, much of it very, very recent, where there is a community of drug developers who are a bit more adventurous and a bit more driven by clinical evidence. and they're reaping some of the rewards of what I would judge to be better cognitive testing. Good, so let's begin. And cognitive deficits in early Alzheimer's disease. When I think about the composition of things like the mini mental states exam, which is now, we have to remind ourselves, almost a 50-year-old test, it's very much predisposed towards the measurement of memory. And it's a bedside global cognitive test, so it's in no sense designed to be a sensitive instrument of cognition. But what is remarkable about it is that there are no elements that measure, for example, working memory or executive function. Two areas I'll talk about a lot in this presentation, and both of which we know to be impaired often very early in the disease process. We also know that it's quite troublesome for patients who have dysexecutive problems and have difficulties problem solving. So it's not as though there's a clinical irrelevance. We hear from our patients that they have difficulties, and it follows, I think, that if we could improve them with treatment, then they would feel that benefit, as would their caregivers. So the cognitive deficits in early Alzheimer's disease, we've come a very long way. I think there's been some wonderful research, particularly in the last 10 to 20 years, and we now have a much more full picture of what it means to have cognitive difficulties in the earliest stages of the disease. And here is a picture of what that might look like. So here I'm trying to do two things. I'm trying to represent our understanding of early stage presentation. So on the left of this slide, you can see a taxonomy for mild cognitive impairment. I'm not going to go into the details of the pathology or the recognition of MCI. I'm going to assert that for me, mild cognitive impairment is just early stage Alzheimer's disease. We happen to put a different label on it, but I think in practical terms, that's really what we're talking about. And one of the things that's really interesting about the taxonomy that we have for MCI, and this is just one, there are a variety, but this is one that's good for illustrating the point, is that it recognizes that patients that present to us in very, very early stages of Alzheimer's disease can do so very differently. Now, it's true to say still that the majority of cases that we see are coming to us because they or somebody close to them has acknowledged that there are some memory difficulties. So amnestic MCI, individuals who have suddenly find that they're forgetting appointments, they may be losing things around the house, and they or somebody close to them is recognizing that their memory is not as good as it used to be. So memory is still very, very important to our understanding of the presentation of Alzheimer's disease, and also troublesome to the extent that we would like to improve memory with treatments if at all possible. So memory is one of the possible presentations. Similarly, you can see people that have memory difficulties, but a number of other difficulties as well. So episodic memory difficulties, but also difficulties concentrating, so attentional difficulties problem solving, so difficulties with working memory, difficulties planning ahead, so difficulties with executive function. Now, they're not as common as those that present with amnestic difficulties, but they're still a very substantial proportion of the patients that we see in clinic. So sometimes they have difficulties across all those areas. However, it's distinctly likely, and we see fairly commonly, cases of individuals that come to see us because their memory is not great, but it's not the most obvious problem that they have. Their difficulties are in concentrating, or in making themselves understood linguistically, or planning ahead, or problem solving. So they're mindful that they're not as good at these things as they used to be, but their predominant difficulty is not a memory difficulty, it's another domain of cognition. And that's a very substantial proportion of the people we see in clinic. Roughly 20% of those very early stage patients we see are presenting with a difficulty in a domain other than memory. That's not to say their memory is perfect, but there's the other domains that are causing them difficulty. And we assume on the same basis that if we could treat and improve those deficits, that would be beneficial for patients and their caregivers. Now, we can also see people with visual difficulties, but one assumes that the variety of presentation we see in the very earliest stages is a function of where the pathology is starting in the brain. So one would normally expect that the hippocampal and parahippocampal regions of the medial temporal lobes will be the primary site of early damage, leading to difficulties with recording new information, so episodic memory. But if you had damage elsewhere preferentially, it's likely that you'd have other forms of impairment. So we presume that the pathology and its location gives rise to the cognitive difficulties that people will present with. Now that could be visual, so if you have pathology in the posterior part of the brain, it might well be that there are issues with recognizing objects, relations in terms of distance, so-called visual spatial abilities. And it could well be that if you've got early pathology in areas of the brain that subserve communication, so making yourself understood and understanding what's said to you, then you might reasonably expect to present primarily with verbal difficulties, communication issues. But the key message, I think, is whilst the majority of people do present with memory difficulties, there's very high probability that other domains of cognition may be just as troublesome and may be more fragile than memory in the very earliest stages of the disease. So I would judge that it makes perfectly good sense to try to improve performance on episodic memory, working memory, attention and executive function, as well as praxis and language. And I think a good measure of treatment efficacy would have elements of testing that maps all of those domains of function. That seems to me a very reasonable start point. Now, what we need to do, I think, then is to evaluate where we are to see how well we're meeting the needs that we think we have when we look at early stage patients and try to improve the symptoms with which they present. So that means we can move very smoothly to a consideration of where we are. And the principal metric to look at here really is the ADAS-Cog. The clinical dementia rating scale is popularly used. That's probably not a good topic for today. I want to focus on the ADAS-Cog, which has for 20 years or more been the primary outcome measure of choice for measuring cognition. And if I get a protocol, as I surely will from a sponsor next week, it's very likely that if they're measuring cognition, they will have selected the ADAS-Cog as their primary metric of choice. So this is the ADAS-Cog. This is a really helpful slide for understanding the content, but also the limitations of the scale. And you can see on the y-axis a variety of subtests. So very important to say, if you're unfamiliar with the ADAS-Cog, it's not a single measure, it's a variety of tests that are added up to come up with a single score of cognition. And there's some good news. So if I direct you to the top of this figure, there are tests of memory. And if I look at the performance of the age-matched control group, here shown in blue, they don't do perfectly. Now that's really helpful. Good cognitive tests are ones that are free of range restrictions. What do I mean by that? Well, I mean that nobody does perfectly, but equally nobody does so badly they couldn't do any worse. So it's free of floor and ceiling effects. That makes for a good test, because if there's decline, I can still measure it, but if I can improve your performance, I can capture that as well. And if you look at the performance of the MCI group here in the light orange, they're not doing as well as the age-matched controls, but they are doing better than people with early stage Alzheimer's disease. And the Alzheimer's patients are doing worst of all, with a small but recognizable difference between those with a CDR of 0.5 and a CDR of 1. Now, the important thing to say about these memory tests is that at the point at which people are scoring in the AD CDR group of 1, they're one word from remembering nothing after about 3 to 5 minutes. So delayed word recall, in even mild patients, 10% of the people we see with an MMSE of 21 or greater will remember none of the 10 words that we showed them 3 to 5 minutes earlier when we test delayed word recall. When you go into moderate Alzheimer's disease, so people with an MMSE of 20 or less, then you start to see about 50% failing to remember any of the words we've shown them just a few minutes before. Okay, so clear evidence that there are memory deficits, but it also raises the possibility of you hitting floor effects. So people are not being able to perform the test at all because they remember no words. That probably means that the neural territory for remembering new information is now so degraded that just simply putting new chemicals into the plumbing of the brain is unlikely to ever improve that. You'd have to restore brain territory, I think, in order to see improvement from floor performance. So far, so good. The memory tests are doing a not bad job. Orientation a little further down, which is sort of a test of memory. If you know where you are in time and space, we presume it's because you knew the address or the day or the date or the season at some point and you're now recollecting what those things are. That's doing a not bad job. The challenge of the ADAS-Cog in mild early Alzheimer's disease is so much of the content. People are performing perfectly when they come into our study, and they tend to stay there for the duration of our treatment period. Now, that's very unhelpful. So if I had a drug that improved praxis or language, but I was using a test where most people performed perfectly at baseline, it's impossible for me to capture positive treatment effects. And this also, I think, creates a false impression. Because these subtests of praxis and language are so insensitive, they don't capture difficulties that patients may have with language and praxis, even though we know that they do have these difficulties. And if we do clinical evaluations and use more sensitive tests, we can quite readily pick up challenges with language, challenges with praxis, that the ADAS-Cog, because it's so insensitive, doesn't capture. So, big problems with the ADAS-Cog outside of measuring episodic memory. But the other thing to say, and you're probably already thinking this yourself, is there are no tests of attention, of working memory, and of executive function in the ADAS-Cog at all. So if I had a drug which improved attention, working memory, executive function, and I was using the ADAS-Cog to measure efficacy, it's simply impossible to detect whether my drug would improve those areas of cognition. Now, that seems to me an obvious oversight, and it's a puzzle to me, candidly, how that hasn't been fixed in the last 20 years. And later in the presentation, I'll show you some evidence that on the rare occasions where we do actually measure executive function and attention and working memory, we can be rewarded with positive treatment effects. So it seems to me that the ADAS-Cog is simply not fit for purpose. It's prone to range restrictions in very early Alzheimer's disease and MCI, and that's incredibly unhelpful, but it just doesn't have good content validity. It doesn't measure the things that we know from clinical experience and the best evidence from research are early in the disease impacted by Alzheimer's disease, and which are also relevant to the function of individuals on an everyday basis. So I hope that that's persuasive, that you would judge the ADAS-Cog as not a bad test of memory, but actually not a good test of any of the other areas of cognition that we know and think are important. So what does that mean when you see data reported from clinical trials? Well, this is the Biogen eMERGE study, ADAS-Cog data, and I was lucky enough to consult on the data when it was first brought in. And I was told that there was a positive treatment effect on the ADAS-Cog. And I said, well, that must be a memory benefit. And the guys at Biogen said, well, how could you know that? We haven't done the subtest analysis. And I explained that the only areas of dysfunction captured by the ADAS-Cog in very early Alzheimer's disease and MCI are the cognitive components that are looking at memory. And this is just the evidence. You don't have to be a magician. You've just got to know the content of the ADAS-Cog to realise that this must be the case. So when we looked at the treatment benefits on the ADAS-Cog in the eMERGE study, you can see that they were nearly all exclusive to the memory subtest, which is precisely what you would expect given the insensitivity of the ADAS-Cog to other areas of cognition, like praxis and language, but also the bits that aren't measured. So, it is odd. We have aducanumab approved, at least on the biological mechanism, as a treatment, but I don't know today what the benefits of treatment would be on executive function, on attention or working memory. And if you use just the ADAS-Cog, it's impossible to have an opinion about any possible treatment effects on those other important and key domains of cognition. Now, we're in an area of new data coming through. So the lecanemab data that was announced in a press release last week, in which we're all very much looking forward to seeing at CTAD, also detected as a secondary measure an ADAS-Cog treatment benefit. But it's almost certainly going to be a memory effect, just for the same reasons as the ADAS-Cog in the eMERGE study was almost necessarily going to be a positive effect on memory, but not praxis or language, because it's the same metric and because the cohorts are very similar. So I haven't seen the data, but I'm happy to predict that when we see the data by subtest, the effects of lecanemab will be peculiar to episodic memory. It's really hard to imagine they could be appropriate to any other areas of cognition. So with lecanemab, we're in the same position. One presumes that lecanemab will go forward and be approved. If it is, it'll be approved, and I won't know, and indeed nobody will know, what the benefits of lecanemab are for key areas of cognition outside of episodic memory. And that feels like a very odd situation to be in. So that's where we are, and is worth contemplating where we need to be. So in the rest of the presentation, I'm just going to talk about how we make sure that we manage to test the right areas of cognition, whether that's relevant and important to do so, and I'll also present some evidence that when you do look at attention or executive function with good outcome measures, you can be rewarded by positive treatment effects. Okay, so in the final part of the presentation, I'm going to give you a snapshot of very highly opinionated picture of where I think we need to be when we're selecting cognitive outcome measures for clinical trials of Alzheimer's disease. This is a really good example and a great place to start. So the drug that Vivoryon currently have under development in a phase 2b study, when we looked at the proof of concept data, there was very little evidence that it benefited memory. But there was pretty good evidence that it benefited attention, working memory, and executive function. And based on that proof of concept data, the sponsor, in collaboration with advisors, decided to make their primary outcome measure in the phase 2b study a composite measure of attention and working memory and executive function. These are two papers that explain that in detail if you want to take a deep dive. The first paper is a description of the proof of concept study. The second paper is a very detailed description of the study design of the current phase 2b study. And the bit that I'd like to alert you to is, in selecting patients for this study, we've decided to use a test, the coding test, which measures attention, working memory, some elements of praxis. And the reason for doing so is because the primary outcome measure is likely to impact those same domains of function. Now, if we thought that the benefits were a memory benefit, then it would make sense potentially to select patients based on mini-mental states exam performance, because the MMSE is very largely a test of memory. However, when the primary outcome measure is attention and working memory, it clearly makes sense to enrich the study population for people that have a measurable deficit on a test like coding as a way of maximizing our chances of seeing a treatment effect. Happily, that's exactly what has been done in this study. So that's about attention and working memory. I'll come back to those themes because there's other good data to suggest we can improve those functions. But let me just take a moment to revisit this slide talking about domains of function. So what might a good test look like in the context of trying to index all the relevant domains of cognition? I think you would absolutely want to measure episodic memory. I think you'd want to measure working memory and executive function, something that we don't currently do with the ADAS-Cog. And I think there's also room to be looking at things like attention. Not unusually, patients come to see us and complain that the big issue they have is an inability to concentrate. And worth saying also, the first stage of remembering new information is the ability to pay attention to it. So that probably does impact their memory as well. So I would judge that a really good measure for use in clinical drug trials is one that measures all the domains of function that are represented on this slide here. And just as a reminder, in the normal course of events, when we use the ADAS-Cog, it's really only episodic memory that gets measured at all well. Everything else really is prone to signaling effects or is just simply not measured at all. Now, what happens when we do look at areas outside of episodic memory? Well, here's an example, and I'll line up a few more in the next few slides. Encenocline is a nicotinic alpha-7 drug. I think it is pro-cognitive. Sadly, it's no longer under development due to some safety issues at high dose. But this is a good example of what you can achieve with thoughtful test selection. So what you see here is a composite of 3 measures of memory from the ADAS-Cog. I've already mentioned that I think the ADAS-Cog, whilst it has its faults, does have good tests of memory. And we've added to that 2 tests of executive function and working memory, phonological fluency and semantic fluency. And the data we got, I think, was pretty compelling. So if you look at the end of study, you can see the placebo group have a little improvement at week 12. That's not unusual. Usually there's a little bit of learning effect. People are often more relaxed at later study dates and they tend to do a little better. But they start to decline, and you can see that there's a rescue effect of the highest dose of treatment. So 2 milligrams of ensinicline yields a statistically significant difference from placebo. And worth mentioning also that there is a dose dependency effect as well. So the smallest dose is essentially the same as placebo. The 1 milligram dose is improved, and the 2 milligram dose is the greatest separation. So this is a composite of memory, of working memory and executive function, that served us rather well as an outcome metric in a compound that looked at nicotinic alpha-7 action, which we would expect to have a more global effect on cognition. So when we look at areas as well as episodic memory like executive function, we are often rewarded with positive treatment effects. Just to think about attention, so this is data that is taken from elderly healthy volunteers and is about to go into studies, we hope, of Alzheimer's disease. Now, these are positive treatment effects detected in normal individuals. These are not people with a disease, and I think most of us sit below our most optimal levels of attention. And I think that there are drugs, typically the class of drugs that Actinogen are developing, that have the potential to improve cognition in even people like us, normal volunteers. One assumes that when you have a group of people that have a deficit, the opportunity to improve performance is increased. So we're very optimistic about what forthcoming studies will show. But these are purposefully taken because these particular tests are digital tests. And I think there's real virtue to measuring certain elements of cognition with digital measures. Measuring attention, measuring working memory, and measuring visual memory is just much more easily achieved with a digital test than it is with a paper and pencil measure. That's not to say I feel that there isn't a place for paper and pencil measures. I absolutely do. And later in the presentation, I'll explain what I think a good combination of both types of approach would typically look like. Just to leave the Actinogen data, this is a composite of working memory and attention with some psychomotor speed evaluation. And it really just a composite measure of that benefit of treatment effect that I showed you on the previous slide. So what is good test selection? How do we know when we've got it right? Well, we should be picking reliable measures, ones that don't change as a function of previous experience. Some tests people just do better on them second time around because they've already seen them once, and that's really very unhelpful. We want to avoid those kinds of practice effects. We also want good content validity. What do I mean by that? I think we need to make sure that the tests we select cover all the areas that are relevant to our interests, which in Alzheimer's disease is essentially all the cognitive domains that we recognize. And they should have assay sensitivity, and that's really just a fancy term for saying this is an outcome measure which has previously detected positive treatment effects. And so I think these are the characteristics of a really good test assessment. If they're easy to administer, that really helps with delivery. And I think that usually means a blend of digital devices and paper and pencil tests. What might that look like? Well, this is, I think, a really good example. If somebody said, John, what is the state of the art for you in terms of a good combination of tests? I would point to the combination that I had the good fortune to put together for Axon Neuroscience. And what you can see here is a number of digital tests of, for example, working memory and attention. But there's added to that some paper and pencil tests of executive function. Now, I don't think there are any particularly good digital tests of executive function, and the paper and pencil tests we have, like verbal fluency phonology and verbal fluency for categories, seem to me to be perfectly good. Remember the ensinicline data. We captured positive treatment effects on a paper and pencil assessment of memory and executive function. But I think a blend of the two, for me, represents the best way to get this done. And I think that actually it's not peculiar to Alzheimer's disease. That blend of tests, I would judge, would be just as relevant to looking at, for example, cognition in dementia with Lewy bodies. This is recent data published in Nature Communications, which is looking at just that indication, DLB. And the good news for the sponsor in this study is that an NTB composite, a neuropsych test battery that looked at attention and at working memory, yielded some positive treatment effects at higher dose. So it seems to be the same kinds of tests can capture efficacy in other indications like dementia with Lewy bodies. Historically, we've also used very similar combinations of tests in psychiatry. This is an example of looking at vortioxetine from Lundbeck, which showed very clear treatment benefits across a number of domains of cognition, all of which we indexed with both paper and pencil and digital tests. In summary, what would I say? I would say traditional instruments like the ADAS-Cog just lack content validity, and that's extremely unhelpful for all the reasons I've mentioned. We have to be sure that we assess all the relevant cognitive domains, and when we're looking at a particular outcome measure for attention, it makes sense to enrich our study cohort for people that have rescuable deficits in the target domains. Ultimately, it's about employing reliable, sensitive, and valid measures. I'm going to thank you for your attention at that point, and I'm going to move to a final slide. This is the promised link to my social media in case you do want to download a copy of the presentation, or if you want to send me a message or inspect those disclosures that I revealed earlier. Thank you very much for your attention. I look forward to our question and answer session.